Hello, ladies and gentlemen. Welcome to this webinar. I'm Subodh Verma, a professor at the University of Toronto in Toronto, Canada, and a cardiac surgeon at St. Michael's Hospital. I'm delighted to share with you my thoughts on the glycemic management in people with type 2 diabetes today. Shown in this slide are my relevant disclosures. Notably, I've been involved in many of the diabetes and heart failure trials with the anti-hyperglycemic agents and also with the ongoing SELECT trial and the ZEUS trial that are listed on this slide. Now, as you all know, no matter where we live in the world, unfortunately, diabetes remains a growing and recalcitrant problem. It's a global epidemic which is on the rise. We know that 1 in 11 adults have type 2 diabetes. By 2045, 629 million individuals will have diabetes. Most of the diabetes comes from low and middle income countries. And finally, we know that a large proportion of diabetes is actually undiagnosed and unrecognized. So some of the statistics that I'm sharing with you may actually be a gross underestimation of the current burden of diabetes. Now, at the end of the day, when the rubber hits the road, diabetes unfortunately causes most of its complications and morbidity and mortality through cardiovascular disease. And therefore, the most important sort of strategy in people with diabetes must be a cardioprotective strategy. I'm not saying that kidneys are not important. I'm not saying that eyes are less important. But at the end of the day, the dominant mechanism through which people will die with diabetes will die remains cardiovascular disease. And therefore, it is our responsibility to choose therapies that are cardiovascularly protective in diabetes. Now, the association between cardiovascular disease and diabetes is well recognized, and a summary of this is shown here from the Emerging Risk Factor Collaboration that looked at about 700,000 people over 100 studies, 52,000 plus events, and demonstrated that the hazard ratio for coronary heart disease in people with diabetes is 2.3, for non-fatal myocardial infarction is 1.8, for ischemic cerebrovascular events 2.27, and for hemorrhagic stroke 1.8. And I think you all recognize that despite advances in therapy, diabetes almost doubles the risk of cardiovascular events. But the good news is that in people with diabetes who have good risk factor control, they are at substantially lower risk of cardiovascular events. And this is shown in this paper from the New England Journal of Medicine from the Swedish Diabetes Register that really reminds us that we can do something for people with diabetes, and that is encouraging good risk factor control. Because compared to individuals with good risk factor control, as you go down this list on the right, you see that as risk factor control is poorer, you see a higher risk of cardiovascular events. Now, I was involved in some of the analyses from a trial called LEADER, which was a trial with liraglutide, in which we demonstrated the spectrum of risk in people with diabetes. As shown here at the top, people with diabetes who've had a prior ischemic event, prior MI, prior stroke, they are at the highest risk, followed by people with diabetes who have not yet had an ischemic event but have established cardiovascular disease. They seem to be second in line. And then, of course, people with cardiovascular risk factors are at the lowest risk of cardiovascular events among people with diabetes. Of course, they are at substantially higher risk than people without diabetes. Furthermore, the number of arterial beds involved is also quite important. So if you have a patient with diabetes who has coronary disease and carotid disease, or coronary disease and PAD, or PAD and CVD, polyvascular disease is associated with a significantly higher risk of ischemic events. From a pathophysiological standpoint, diabetes through various important mechanisms listed here: oxidative stress, inflammation, insulin resistance, vasculopenia, can lead to effects on the vascular endothelium, leading to an increased risk of atherosclerotic events, as shown in the slide on the left-hand side. This, of course, is a dominant mechanism of how MACE events occur. But what we've also realized is that these very same mechanisms can also be driving direct injury at the level of the myocyte. And in fact, cardiomyocyte injury and resultant effects on heart failure can ensue, such that in people with diabetes, it's not just about the pipes. It's not just about atherosclerotic events. It is also about the pump. And of course, it is also about the filter or the kidney that is listed here, which by itself is an important mechanism through which end-stage renal disease develops. But don't forget, as people develop renal disease, they are at very high risk of cardiovascular events, something that we've learned, and I will stress on towards the end of my presentation when I talk about the number of years gained by GLP-1 RAs and how that relates to people with diabetes who have renal disease. Now, with all of that background, how is it that we reduce risk in people with diabetes? What's the approach? And as they say, no one person or one strategy is stronger than a team. It never works. It's always a team and a multifactorial approach that wins. And that is how we're going to win the war against diabetes, is by everybody working to reduce risk. And in this slide, that concept is illustrated, that in diabetes, the ability to reduce risk factors in a multifactorial fashion is paramount. For example, lipid-lowering therapy, statins, ezetimibe, PCSK9 inhibitors, icosapent ethyl, strategies that reduce lipids and triglycerides are imperative. From a blood pressure standpoint, reducing blood pressure with ACE inhibitors, ARBs, and other strategies down to a blood pressure 130/80 or even lower is important. Using antiplatelet strategies, aspirin, in secondary prevention, dual antiplatelet therapy in certain patients. What about low-dose rivaroxaban, as shown in the COMPASS trial? All important. Multifactorial, multifaceted approach to reducing risk in people with diabetes. But what about sugar? What about A1C? Does it matter how you lower sugar? Now, prior to the FDA guidance, we just said get people to an A1C of less than 7%. And we said if you can do that without causing hypoglycemia, that would be wonderful. But now we say the way you get there matters. And that is the key message for all of us. That it's not just getting to target, it is how you get to target matters. And the cocktail must include a GLP-1 RA or an SGLT2 inhibitor in the vast majority of patients. Is metformin required? What about sulfonylureas? What about DPP-4 inhibitors? All of that, in my mind, takes second place to the dominant role of SGLT2 inhibitors and GLP-1 RAs for cardiorenal protection. So to be able to illustrate that, I want to share with you this case of Abdul, who is 66 years of age. He's had diabetes, dyslipidemia, obesity, and has had a stroke 3 years ago, and also has an ankle brachial index of 0.8. He's 66 years of age. He's not that old. His A1C, by most accounts, is reasonable. Many of you would look at 6.8% and give a thumbs up, say, that's pretty good. What else do you want me to do? Well, let's see. He is a remote smoker. He's significantly overweight or obese, a BMI of 33.5. His blood pressure is sort of okay. 135/84 is not where I would like to see it, so certainly has room to improve. LV function is normal, no heart failure, and kidney function is relatively preserved. So you have an obese patient with diabetes. You have a patient who is relatively young, 66, and he's already had a stroke and he has PAD. So if this doesn't send the alarm bells to you and your patient, that this is a patient whose life expectancy is much shorter, he may get a second stroke or a second heart attack or die. He is at risk of amputation because of having PAD. This is a very high-risk patient. So this is not about what strategy. This is about everything on the table intensively to improve this patient's outcome. But when we look at the medication list for Abdul, you see that the SGLT2 or GLP-1RA is actually missing. And we see this now in many patients, that people are on DPP-4 inhibitors, A1C is reasonable, and physicians and patients say, well, I think I'm okay. I'll take a pass, I'll wait. I'm doing pretty good, my sugar is okay. But until we are able to communicate to our patients the fact that these glucose-lowering medications are not just for glucose, but they are for cardiovascular protection, and they do two things, we won't be able to overcome that discussion with our patients, because that is the first question that comes up. But sir, doctor, my sugar is okay. I measure it 3 times a day, I measure it 5 times a day. The family is there. Oh, he's eating quite well these days. He's lost some weight, his sugar is okay. But we need to find ways to communicate that these are therapies that have 2 effects. One is that they lower sugar, second is that they protect the heart. And it was not until I started doing this with my patients in Canada that I was able to overcome inertia in this regard. So how do you want to progress or proceed with this patient? Should you say that the A1C is okay and I'll wait? Would you add an SGLT2 inhibitor or a GLP-1RA? Would you replace the sitagliptin with a GLP-1RA? Or would you wait for A1C to deteriorate? And that's the question for us to address. Well, thankfully, the 2019 European Society of Cardiology guidelines have addressed that for us. They said that if someone has risk factors or established disease like Abdul, you should immediately start them on an SGLT2 or a GLP-1RA. It's not about SGLT2 or GLP-1RA. These new drugs must take precedence over other standard of care in people with diabetes. It is required, even if the A1C is normal, and even if patients are not on metformin. And that sentiment was a really important step forward to be able to really move the needle forward for patients with diabetes, saying that it's not just very high-risk patients like Abdul. It is not just people with established disease, but what about someone with diabetes who has 3 risk factors? That's also a very high-risk patient. A patient with diabetes who's a smoker, who's overweight, and has hypertension. That's a very high-risk patient. Someone with diabetes for 10 years is a high-risk patient. So the vast majority of people we're going to see today are candidates where therapy with either one of these strategies must be prioritized. And this sentiment also is echoed in the guidelines. The clinical practice guidelines for SGLT2 inhibitors on the left and GLP-1RAs on the right clearly articulate the class 1 indication in high/very high-risk patients to reduce cardiovascular outcomes. This sentiment is echoed for cardiologists in the American College of Cardiology guidance that say that if you have a patient who is over the age of 18 who is at high or very high cardiorenal risk, that they should be prescribed either an SGLT2 or a GLP-1RA in the vast majority of cases, and that this sentiment is further echoed by the American Diabetes Association, that in this very complex algorithm has said that irrespective of A1C, independent of A1C, you should be using these therapies. So it's not about what is your sugar control, it's about what is your risk. Do you have diabetes? Yes. Are you at high or very high risk? Yes. Then you should get a GLP-1 RA or an SGLT2 inhibitor. It's not about, do you have diabetes? What is your sugar? That's the wrong pathway. It's about, do you have diabetes? Yes. Not what's your sugar, what's your CV risk? And then making sure you incorporate these new therapies to reduce outcomes in these patients. That's the new paradigm today. And we're very fortunate to really have made such progress to be able to ask such bold and important questions on behalf of our patients. So in Canada, we have incorporated both the GLP-1 and SGLT2 inhibitors in our guidelines, giving a strong recommendation for either one of them for MACE reduction, a strong indication for SGLT2 inhibitors for heart failure and nephropathy protection that is highlighted in this slide here. So now I ask you, friends, what would you do for Abdul? What would you do if you were Abdul and you had a condition like this? Would you wait for the A1C to deteriorate? Would you add either an SGLT2 or a GLP-1 RA? It would be hard to add a GLP-1 RA if the patient is already on sitagliptin, and therefore I think the third option of replacing sitagliptin with a GLP-1 RA is important. I discontinue DPP-4 inhibitors more now than I ever have and replace them with new therapies, and I'm sure you do that as well. This will reduce weight, improve A1C, protect against cardiovascular events, reduce albuminuria, reduce blood pressure, and extend life. I think that's a really important outcome. And I certainly don't think we should be waiting for the A1C to deteriorate. Now, the GLP-1 RAs, which are the topic of the next 10 minutes of my presentation, have really been transformative. And you can see that many trials have been done to underscore the benefit of this therapy in cardiovascular protection. It's a very busy slide here to share with you, but I want to just make a point that people with diabetes were studied if they either have established disease or they have multiple cardiovascular risk factors. So we know both primary and secondary prevention populations with the context of diabetes have been evaluated in these large CVOTs with GLP-1 RAs. And collectively, they have suggested that they reduce MACE by about 12%. They reduce cardiovascular death by about 12%, both highly statistically significantly with several zeros in the p-value. They reduce fatal and non-fatal myocardial infarction by about 10%. They reduce stroke by about 16% in people with diabetes, with or without, again, established disease. And it seems that those agents that have a human homology seem to behave a little bit better than those that are not homologous to human GLP-1. And the latest meta-analyses by Professor Naveed Sattar in the Lancet Endocrinology, as published here, suggests that now, including the last trial called Amplitude-O, that there is a 14% reduction in MACE events across the broad population of primary and secondary prevention patients with type 2 diabetes. Now, I want to really focus on semaglutide. Semaglutide is a dominant GLP-1 RA. At least in Canada, it has been extremely popular among patients and physicians. We're going to spend a few minutes talking about sub-Q and oral semaglutide. So, as you know, semaglutide is a human GLP-1 analog. it has 94% homology to human GLP-1 and has a half-life of about 7 days. In the SUSTAIN-6 trial, which was a trial of cardiovascular safety, you can see that the hazard ratio in people with diabetes who either had established disease or multiple risk factors for the MACE outcome was 0.74. So this is consistent with a 26% relative risk reduction for major adverse cardiovascular events in this broad population of people with diabetes who receive semaglutide 1 milligram subcutaneously weekly. Now, what is the rationale for oral therapy? I think it's self-explanatory. Why should we use oral therapy? Well, first of all, the moment you talk to a patient with diabetes about an injection, there's often a sense of, am I really that bad? Have I got to the point, doctor, that I need an injection? I think the world is changing. I think people are realizing that there's new ways of giving therapy, and it's not insulin, and many therapies have to be delivered that way. Quite frankly, subcutaneous semaglutide is extremely well received by our patients because once a week dosing by many is considered to be even easier than an oral pill every day. But nonetheless, flexibility is important. Tailoring the approach to what our patient wants is important. I think that's by and large the most important reason to have it, because not one solution can fit everybody. Some patients want an oral therapy. Some people are okay with a subcutaneous once weekly strategy. But as you know, getting oral GLP-1 to work is nothing short of a pharmaceutical chemistry sort of major advance, because the stuff it gets degraded very quickly in the gastrointestinal tract. So real congratulations to Novo Nordisk for developing the oral semaglutide and studying it with such gravitas. 19 clinical pharmacology trials, 1 phase 2 trial, 10 phase 3A trials, over 10,000, close to 10,000 patients enrolled, and 5,000 plus patients subjected to oral semaglutide. It's a very, very impressive program called the Pioneer Program, and I'm just going to share with you the results from the cardiovascular safety trial of Pioneer called Pioneer 6. So Pioneer 6 was essentially a trial trying to look at safety of semaglutide, 3,183 patients. They were enrolled and they were randomized to receive oral semaglutide, 3 milligrams, 7 milligrams, and then 14 milligrams orally daily versus placebo. Patients were enrolled in 2 strata. People could get in if they were over the age of 50 with clinical evidence of cardiovascular disease or chronic kidney disease. Patients could also be enrolled if they were over the age of 60 and had just cardiovascular risk factors alone. Of course, they had to have diabetes, and the primary outcome was the composite outcome of CV death, MI, and stroke. Now, let me just tell you about the types of people that went into the Pioneer 6 program. Their mean age was 66. They were predominantly men, 70%, with an A1C of about 8.2%, about 14 years of diabetes, as you can see here, and these were people that were significantly overweight with a BMI of 32. 11% were current smokers, and the eGFR was 74. The mean eGFR was 74 at baseline. And as you can see here, 1/3 of the patients had a normal eGFR above 90. 43% had mild renal impairment defined as a GFR between 60 and 90 mils per minute, and about 26% had moderate renal impairment defined as a GFR between 30 and 60 mils per minute. Let me also tell you a bit about the overall numbers of patients per strata. So 85% of patients were enrolled by virtue of being over the age of 50 and having a presence of CV disease. and about 15% got in because of the second inclusion strata, which were people over the age of 60 with CV risk factors alone. And shown here are the time to first event analyses, the first MACE, the primary endpoint showing a hazard ratio of 0.79, confidence intervals 0.57 to 1.11, few events, but clearly the point estimate pointing towards a benefit, a numeric benefit of oral semaglutide in this regard. Of course, this did not achieve statistical significance because of the number of events, but it was clearly safe with a p-value of non-inferiority of less than 0.0001. Now, when we looked at the individual components of the primary outcome, cardiovascular death, the hazard ratio was 0.49. First non-fatal stroke, hazard ratio 0.74, and first non-fatal myocardial infarction, hazard ratio of 1.18. Now, the expanded MACE outcome is shown here with a hazard ratio of 0.82, and this expanded MACE now also includes unstable angina or heart failure requiring hospitalization, which, as you can see in the next slide, really were not numerically different between the two strategies. What is really encouraging, and of course I know that this is early days and small number of patients, but it is incredibly exciting to see that the hazard ratio for all-cause death was 0.51. There were 30 cardiovascular deaths in the placebo arm and 15 cardiovascular deaths in the semaglutide arm. And I think at the end of the day, this is why we investigate these potential therapies, not just to reduce A1C, but to extend life. And I think this is a really important, early sign of what may be occurring with this therapy to really change the path of patients with type 2 diabetes. Now, of course, semaglutide is a dominant strategy with respect to A1C lowering, and we see that as shown here. There was a reduction in hemoglobin A1C that was seen early and sustained. There was a reduction in body weight that was quite substantial with oral semaglutide and mirrors what is seen with subcutaneous semaglutide, again early and sustained. And the side effect profile is actually entirely neutral. So there's really nothing to be concerned about here. And those of us who have used oral semaglutide at least can attest to that in our own clinical experience, that the therapy is tolerated with some GI, dyspepsia and nausea, and in some cases constipation, as we see with, subcutaneous semaglutide, but it is resolves early, and very few patients, if any, actually discontinue therapy because of the side effects. And that's shown here. Overall, the benefits are associated with no real safety concerns. Diabetic retinopathy in trial, 7.1 in semaglutide treated versus 6.3 in placebo. And, a lot has been written about the risk of diabetic retinopathy that was seen in the SUSTAIN 6 program, and that was mostly seen in people who had some degree of diabetic retinopathy to begin with, or in those that had pretty significant drops in the A1C rapidly. Now, what is incredibly important is that we have two trials now with the same molecule. One is oral semaglutide and one is subcutaneous semaglutide. And an effort has been made to pool together the two trials to increase power and to try to make some sense of where is the dominant cardiovascular benefit observed. So this is the pooled analyses of SUSTAIN 6 and PIONEER 6, and as you can see here, when put together, they show a clear 24% relative risk reduction in the outcome of MACE. So this strategy appears to cut the risk of major adverse cardiovascular events in people with diabetes across a broad spectrum of primary and secondary prevention by about a quarter. And I think that is something truly remarkable, because this is on top of standard of care, on top of an ACE inhibitor, a beta blocker, on top of statin, on top of LDL cholesterol lowering. This is an entirely complementary approach to reducing cardiovascular risk by 1/4 in people with diabetes. Now, when we look at the overall benefit observed by evidence of cardiovascular disease or not, again, you see here no heterogeneity. The p-value for interaction is 0.944, suggesting that the benefit of semaglutide is consistent in people with and without established cardiovascular disease, is consistent in people with and without a prior MI or stroke, but appears to actually be neutral in those individuals with a prior history of heart failure. Now, in the last few minutes that I have left, I'd like to introduce this really interesting concept of life years gained. What do you mean by that? What do I mean by that? This is a great way of communicating the benefit of therapy with our patients and with other, individuals, physicians, and payers about what does this mean to Abdul, who's sitting in front of me. If I was to give Abdul this strategy of semaglutide, what does it mean? 24%? That doesn't really mean much to him. How many more years are we adding? How many more life years without a cardiovascular recurrent event are we adding for this patient? And I think that's the illustration that SUSTAIN 6 and PIONEER 6 in a pooled analysis has been able to achieve by trying to do these sort of actuarial calculations. And in this recently published and presented paper, the attempt was made in the pooled cohort to try to define this outcome of life years gained without a CV event. And what was done was a model using the DIAL model, which is a fully validated model of lifetime risk developed from the Swedish Diabetes Register that captures fully adjusted models of CV death and non-CV death in patients with diabetes, was applied to the pooled estimate of the SUSTAIN 6 and the PIONEER 6 data set to ask the question, how many years were gained without a cardiovascular event in patients who received semaglutide? And as you can see here, the distribution is quite broad. On the left, some people with established cardiovascular disease can gain about a year. Some people can gain up to 3 or 4 years. And not shown here is actually another analysis that was done that suggests that the younger you are, the more is the life years gained. And that's because you have more years ahead. So a 40, 50-year-old who gets semaglutide gains significantly more life free of cardiovascular events than someone who is elderly. And that makes sense. If you've got more runway ahead, you've got more to gain. But clearly, in people who have established cardiovascular disease, there's no doubt that where the mean increase is about 1.7 years, some people may derive even more. And I would suspect that a young person like Abdul that I presented to you today with a prior stroke and with prior PAD would be one that would gain closer to 3 to 4 years. Now that makes a lot of sense when you're having that discussion with the patient to say, if you are initiated on this therapy, sir, you are likely to gain 3 to 4 more years of life free of having a recurrent ischemic event or dying. And I think that makes the conversation real. And it actually allows for people to understand the gravity of what is it that the physician is trying to discuss with them. Now, of course, on the right is people who gain the least, are people who have the lowest risk without cardiovascular risk. factors. But you can see in the gray are people who have CKD. And what has really surfaced again from this analysis is that when you're faced with patients with GFRs below 60, or someone who's spilling albumin, they may not have had a cardiovascular event, but they are at very high risk of having a cardiovascular event. And as you can see here, tend to derive a greater benefit with respect to life years gained free of a cardiovascular event compared to those individuals who have no cardiovascular risk factors. So I think this is a really important observation that highlights a way to quantify the benefits of semaglutide in terms of freedom from cardiovascular events moving forward. Now, how do these therapies work? They have potential direct effects at the level of the vasculature that are listed here: endothelial function, smooth muscle cell proliferation, migration, inflammation, LDL oxidation. They have indirect effects through blood pressure, weight, and reduction in A1C, all of which can affect the atherosclerotic milieu and reduce cardiovascular events. But someone asked me recently, and that's why I put up this slide from Dr. Caruso, is does A1C reduction matter when it comes to GLP-1 RAs? And, again, this is a hard one to tease out. And what has been done is a meta-regression analysis. Shown on the vertical axis are the hazard ratio for the various outcomes, and on the horizontal axis is the A1C mean difference. And what you can see here at the bottom is that when it comes to the effects of GLP-1 RAs on CV death and on myocardial infarction, they actually seem to be largely independent of their effects on A1C lowering per se. The effects on MACE and stroke appear to be more dependent on A1C reduction. I'd like to finally really conclude by highlighting one analysis that we led, and that was looking at BMI, because many people believe that a GLP-1 RA should only be given to someone who is obese. And I think that's really important, but the benefits are seen consistently in people with or without overweight. And this was an analysis from LEADER and SUSTAIN-6, where we demonstrated that there was a consistent benefit to reduce MACE events in both of these trials, irrespective of baseline BMI, less than 25, 25 to 30, more than 30, or more than 35, respectively. So now looking into the future, where are we headed? There's the large SOUL trial, which is the oral semaglutide cardiovascular outcome trial that is ongoing, about 10,000 patients, 14 milligrams of semaglutide versus placebo. And this is a trial that will evaluate the potential superiority of semaglutide on cardiovascular outcomes in a broad population of people with type 2 diabetes. So in conclusion, ladies and gentlemen, I'm reminded of the 10 commandments that the 2019 ESC put forward, where they said SGLT2 and GLP-1 RAs are recommended as first-line therapy in people with diabetes at high or very high risk. And this is intended for cardiologists. And think diabetes when you're thinking about reducing cardiovascular risk. So at the end of the day, with all of this great data, why are we not winning the war against diabetes? What is the significant hurdle? What are the impediments? And I would suggest that our biggest enemy in this war against diabetes is actually inertia. It is not the lack of data. It is not the lack of trials. It's not the lack of education. It is inertia. And sometimes physicians play a very important role in that inertia. I know inertia and knowledge transfer can often be multifactorial. There's physician factors and patient factors and system factors and cost factors, and it's multifactorial. But just be cognizant that oftentimes, it is therapeutic inertia on the on the healthcare provider's side. He's stable. I hear this from my colleagues many times. Oh, you know what, Dr. Verma, he had an MI and he had some heart failure, but he's stable. I don't know what that means. Are they stable until they have a second event? Or, you know, he's doing just fine. Let's reassess him in 3 months. But why? What are we waiting for? You know, it's like saying someone has cancer, but let it spread a little bit and then we'll reassess it. I don't understand what that means. Or someone may say, you know, at least in the heart failure realm, I'm a cardiologist, I don't do diabetes, that's for somebody else to do. Or I'm really scared these drugs are going to cause hypoglycemia. But they don't, and we've said that multiple times. It doesn't cause hypoglycemia, particularly when it's added to people who are not on insulin or not on sulfonylurea. But sometimes what we're trying to say is that I hope that someone else will take care of this problem for me. It's not my problem. And it is our collective problem, because diabetes is not a disease of cardiologists or endocrinologists or family doctors or nephrologists. It is a societal problem for which all of us have the tools, and all of us must be not only responsible but accountable for the strategies and the choices we make for our patients. So we've come a long way, ladies and gentlemen, in our fight against diabetes, as I've shown you here. It is a time to celebrate the advances that science has made, and we really need to find ways to get these therapies in the hands of patients who need them the most. So with that, thanks so much for your attention. I hope you've enjoyed today's webinar, and I look forward to seeing you in person in due course.